Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips and Practical Tips. What I'm going to be sharing with you today is a nice case of metastatic carcinoma masquerading as GBM. So this is a case of a 62-year-old male patient who presented with headache, and on imaging, he was found to have large brain tumor with extensive peritumoral edema. And the differential diagnosis radiologically was between GBM and solitary metastasis. And the reason why they suggested solitary metastasis is the presence of extensive peritumoral edema. And this is the resected specimen from the craniotomy. And as you can see, there is a tumor here with large areas of necrosis. Not much in the way of palisading, but definitely there is necrosis. And then there is some reactive tissue, reactive brain tissue here at the periphery. And on high power magnification, these are the tumor cells and these are the areas of necrosis and what looks like microvascular proliferation, not really the typical microvascular proliferation that we see. And on even higher power magnification, we can see the tumor cells with like vesicular nucleus, small inconspicuous nucleoli, not much in the way of any clues to the diagnosis. And based on the radiological findings and suggestions, the immunostain was performed having both differential diagnosis in mind, whether this is a GBM or this is metastatic tumor from somewhere else, in particular metastatic carcinoma. And this is the GFAP immunohistochemistry. And as you can see, most of the tumor cells are negative. There is mitotic figure here. There are scattered positive wisps of GFAP positive perhaps processes. There wasn't a clear evidence of positive GFAP cells, but then even with sometimes high-grade gliomas, sometimes GFAP can be negative. So this does not rule out 100% the diagnosis of glioblastoma. Now, CAM5.2 as one of the pan-cytokeratin markers showed only focal positivity in some of the tumor cells. The other pan-cytokeratin was almost completely negative. What was really useful is the EMA or the EMA, as some people call it, because positivity was strong and diffuse in most of the tumor cells. And this caused us to further or to move more slightly towards the diagnosis of metastatic carcinoma more than glioblastoma. So we started to use some transcription factor, immunohistochemistry, or some immunohistochemical markers that can help in defining the origin of the tumor. And a large panel of immunohistochemical stains was utilized. The tumor cells turned out to be TTF1 positive. So again, gaining further evidence in support that this might be metastatic carcinoma. Synaptophysin was also positive in the tumor cells. Chromogranin showed some scattered positivity, and P53 was strongly diffusely positive. Really, P53 would be quite unusual in a glioblastoma in an elderly patient. P53 is usually positive in a glioblastoma in younger individuals in association with ATRX loss and frequently IDH mutation. Nonetheless, P53 alone would support that this is malignant, would not really tell you what is the origin of the tumor. Now, based on the findings, I contacted the physician and requested imaging of the body. And what happened is that 4 times 3 centimeter left hilar mass was identified, and the patient actually turned out to be smoker as well. So the final diagnosis in this case was metastatic poorly differentiated carcinoma of pulmonary origin, showing some neuroendocrine features. Please remember that GFAP stain can sometimes be negative even in primary glioblastoma. So this does not rule out the diagnosis, and that even pan-cytokeratins, including the CAM5.2, tissue can sometimes be negative or only show focal positivity in high-grade carcinomas, especially the poorly differentiated carcinomas. So we have to resort to other immunohistochemical stains. Something like EMA would be extremely helpful. Correlation with the clinical findings, with the imaging findings, communication with the rest of the clinical team is extremely important in rendering a support to the diagnosis, as is this typical example that I'm sharing with you. And please listen to your radiologist, because the radiologist, because of the extensive edema, they were inclined to favor metastasis over glioblastoma, although they were not quite sure. Remember that metastatic carcinoma, in particular of pulmonary origin, can have presentation as a brain metastasis as their first presentation. So this should be kept in mind. I hope you find this tip useful in your daily practice. Thank you.